Thank you very much indeed, and it's a great honour to be here. Donald, thank you very much for the invitation. I'm looking forward to the day immensely, that part of it that I can join you for. Could I start by asking whether there are any neonatologists or paediatricians in the audience? One hand, is that right? Gosh, I'm glad you're here. So I would like to talk about preterm birth and disease in adult life, because this is something that has, I hope you will agree by the end of my talk, this is something that should have resonance across the whole of medicine. And just to give you a teeny bit of background to start with, when I was in training, neonatal intensive care had barely got underway. It really came into its own in the late 1970s and the 1980s. And of course, at that time, it was all about enabling very sick babies, very preterm babies and very sick babies to survive. And as the decades went on, the focus moved from survival, because we got better at keeping babies alive, the focus moved very much to intact survival. So avoiding particularly brain injury and lung injury, and sending babies home ostensibly healthy and well. But again, as the decades have moved on, we're now really, because we've been so successful, I think, we're now really focused on what the health outcomes of these children are in adult life. And that's what I'd like to talk to you about today. So I need to begin with my disclosures. Please be aware that I'm a member of the Nestle International Scientific Advisory Board. I'm the only paediatrician there, but I accept no financial remuneration for that. I do no contract research. I've received conference travel from the following industry organizations, and in the last 5 years from the following public bodies, government bodies, and industry sectors. So the summary of my talk is what is known, to describe for you what is known about the adult phenotype of the baby who is born preterm, and the implications for clinicians, for clinical scientists, and indeed for families as well. And I'm sorry, but I will not have time, but this is the other very interesting aspect, which would be great to discuss with you, but there won't be time to go into the possible mechanisms underpinning the phenotypic associations that I'm going to describe. So also, please be aware that preterm birth is not a niche area. It is a growing and very important global issue. You will see these data here from the World Health Organization, which gives you preterm births per 100 live births. We in Europe and in the UK are fortunate. Our preterm birth rate is still less than 10%, but there are other countries in the world, most notably the United States, where the preterm birth rate is substantially higher. And there are, I think, about 14 or 15 countries around the world which have the ignominious position of having a preterm birth rate of more than 15%. They're mainly in They're mainly in sub-Saharan Africa, but also you see Indonesia and Pakistan, where the rates are extremely high indeed. And in absolute numbers, the volume of preterm babies being added to the general population is, of course, growing hugely. Now, I mentioned earlier that neonatal medicine has become very successful in terms of survival. And most very preterm babies, moderately preterm babies, late preterm babies, 99.9% will survive to go home. But even for the most immature babies, and here you see 23 weeks gestation, 24 weeks gestation, and 25 weeks gestation. And these are some data we published last year, which come from the National Neonatal Research Database that I lead, which contains information on every baby admitted to an NHS neonatal unit. And you'll see here the steady increase in survival for these very low gestational age babies. And of course, this is a pattern that is being replicated in high-income countries around the world. So as I said previously, more and more very preterm babies are being added to the total population pool. Now, my own research group got into the issue of long-term outcomes through, as is often the case in medicine and science, through a serendipitous observation. So a PhD student of mine, Sabita Uthaya, wanted to evaluate the body composition of very preterm babies when they reached term age. And these babies outwardly are very skinny, they're very small, and there was and there remains a great deal of concern about growth failure in very preterm babies. But what she found using whole body MRI, so our baby is fed and swaddled, earmuffs put on, and the baby sleeps as he or she is slid through the bore of the magnet. We then take slices, images at 5 millimeter intervals. We color code them according to adipose tissue and non-adipose tissue. We summate the images and we get a very accurate measure of body composition. And what she found was that preterm, when they reach the age of full term, have a substantially increased internal abdominal adipose tissue compartment, even though outwardly these babies look scrawny and skinny. Now, we also, around about that time, showed in a number of studies where we replicated the finding that using proton spectroscopy, liver hepatic proton spectroscopy, to evaluate the fat content, the intrahepatocellular fat content, we also noticed that preterm babies, so this is a proton spectrum from the liver of a preterm baby at term, this is from a healthy full-term baby. You can see the tiny fat peak here, and in contrast, the very marked fat peak there. So these babies also have very substantial intrahepatic lipid content. And also around about the same time, authors from around the world were pointing to the fact that in young adults who had been born with a very low birth weight, in other words, who were very preterm, had abnormal glucose regulation. And so we said to ourselves, well, perhaps what we're seeing, the excessive visceral adiposity and the excessive hepatic lipid, which of course are biomarkers for later glucose dysregulation, perhaps this is part of the causal pathway that is leading to this glucose dysregulation in preterm adults. And so we next asked the question, is there evidence of altered adiposity in young adults who are born preterm? And the answer to that is yes. So in 2011, we published this paper, which was a small study of a group of young adults who were aged 19 to 25 years old in comparison with full-term counterparts. These were outwardly healthy, fit young individuals on no medications, no diseases whatsoever, but their phenotypes were very, very different. So in comparison with the adults born, who'd been born at term, those born more than 8 weeks early, below 32 weeks gestation, had a very substantial increase in visceral adiposity. They had a 3 times higher intrahepatocellular lipid content, higher blood pressure, of note, a lower body mass index, and also a significantly different urinary metabolome. And pediatric research published metabolic spectra on their cover, but they got it upside down and they got the men and the women wrong, but never mind that. No one's written to me to complain about it. So just to summarize this bit of evidence. So in 2005, we showed that preterm babies, when they reached full-term age, have increased internal abdominal adiposity. In 2011, we showed the same for a small group of preterm young adults. In 2018, funded by a grant from the British Heart Foundation, we conducted a study to try and replicate this finding, and indeed we did replicate this finding, and this paper is now in press. And now in 2019, because of course these 3 previous studies were cross-sectional studies, but in 2019 we've now commenced a longitudinal study where we're aiming to re-image children who we imaged initially as newborn babies. So we're asking the question, do we have evidence of tracking of this aberrant body composition? So we should have those data available in the next 2 years. Now, what else is out there? Because of course we wanted to look for corroborative evidence. So this is a systematic review and meta-analysis published in 2013, examining waist-hip ratio as a proxy measure for increased visceral adiposity. And what we found in summary is indeed that waist-hip ratio is greater in ex-preterm young adults compared to term adults, but if anything, body mass index is lower. It's certainly not increased. So in other words, evidence not of obesity, but of an aberrant body composition. Now, the implications of this, I need not tell this audience. This is your territory, not mine. But of course, this is important to my neonatal colleagues because, of course, internal abdominal adiposity is a biomarker for altered metabolism and an independent predictor of mortality. This is a Canadian study which here shows risk of death on the y-axis, and on the x-axis, the volume of internal abdominal adipose tissue. The difference between these two individuals is 0.5 kilo. I'll remind you that that's the average increase we found in our young adults. And of course, this represents a twofold increased risk for mortality. So the next question we asked is there indeed evidence of increased mortality in young adults who are born preterm? And shockingly, there is very strong evidence indeed. This comes from Casey Crumps and colleagues. They have been using the Swedish birth registry data. And of course, our very preterm babies are now only reaching the age of about 40 or 50, because as I said to you, neonatal intensive care really only got underway in the early 1980s, the late 1970s. But you will see here some really, really striking data. Here you have age in years up to the age of 40, and on the y-axis you have the adjusted hazard ratio for all-cause mortality. This horizontal line is the full-term reference. This red line is extremely preterm babies, less than 28 weeks gestation. And you will see that there is evidence of a dose-response relationship with increasing all-cause mortality, which persists into adult life and is dependent on the degree of immaturity. Very, very stark data indeed from a very large population-based study of 4.3 million individuals. So what else do we know about the phenotype of these adults who are born preterm? Well, this again comes from our systematic review and meta-analysis of 2013. This is in relation to blood pressure. The figures, I'm sorry if you won't be able to see them, but they're quite substantial sizes here. We've got, for our term babies, almost 300,000 individuals and about 16,000 preterm adult individuals. The average increase in systolic blood pressure is 4.2 millimeters mercury, and for diastolic blood pressure, it's 2.5 millimeters mercury. Now, I think these are pretty substantial effect sizes. There's also more evidence of a continuum of impairment depending upon the degree of prematurity. So here we have more Scandinavian data. This is from young men who have been recruited into the army. And here you see the adjusted odds ratios for high systolic blood pressure in relation to gestational age, with the most immature here having an adjusted odds ratio of almost twice that of full-term counterparts, but the effect significant even at these more moderate preterm groups. And of course, that is of relevance to us because of the fact that an increase, every 2 millimeter increase in systolic blood pressure is associated with a substantially increased risk in mortality from ischemic heart disease and risk of stroke. And so again, we went to the literature to ask about other corroborative evidence. And here we find data from Scandinavia here. This is shorter length of gestation associated with higher mortality from cerebrovascular disease, and again, increased risk in this study here, also from the Swedish birth registry here. Birth before 32 weeks associated with a nearly twofold increased risk of cerebrovascular disease. So data coming in from multiple sorts of studies and different parts of the world, all pointing to the same conclusion. Here we have data about the prevalence of type 2 diabetes, again, substantially higher in adults born preterm. You can see there the odds ratios of 1.68 for adjusted risk. And more data. This is a very interesting exposure-wide umbrella review of all meta-analysis. This was published just last year. And here you will see too preterm birth popping up with an effect size here of 1.5, way over to the right of the vertical line, and again providing rather global evidence of definitely an increased risk of type 2 diabetes among young adults who are born preterm. What about the full-blown metabolic syndrome? The same story again. Here you have hypertension, obesity, and full-blown metabolic syndrome, fatty liver index for early preterm, late preterm, and term. And again, this very clear gradation and a very clear indication of increased risk. A little bit now about what might be the pathways underpinning these functional outcomes. So here I've summarized some work from Paul Leeson and his group in Oxford. Paul is a professor of adult cardiovascular medicine in Oxford, and he's been studying young adults who are born preterm and has shown that they have an aberrant and an adverse cardiac morphology. Their left ventricles are shorter, they have reduced cardiac volumes, they have apical displacement, and he's computed that their left ventricular mass is increased by an average of 19 grams, and suggests that this equates to a more than 50% increased risk of cardiovascular events in adult life. Again then, what evidence is there from our epidemiological colleagues? But first, what evidence is there in relation to biomarkers? So this is a study in 5 to 7-year-old children showing, again, as we already know very well, an increase in blood pressure, systolic and diastolic blood pressure. But here we see, again, evidence of altered glucose homeostasis and abnormal lipid profiles with an increased cholesterol in the preterm group. And again, we see the same thing in adolescents born preterm, with emerging, and this is another very interesting point, emerging differences between men and women. So here you have boys born late preterm, boys born early preterm, and here girls and late preterm and early preterm. And you will, this comes from the Northern Finland birth cohort, and you'll see that the girls have an increase in blood pressure, but not the boys at this stage. These are adolescents. But the boys have a higher total cholesterol, LDL cholesterol, and apolipoprotein B, but the girls show no differences at this age. Here are the epidemiological data relating to heart disease. So again, from Casey Crump's group, here you see preterm, less than 37 weeks gestation, a substantial increase in the hazard ratios for ischemic heart disease between the ages of 18 and 43, and again, evidence of a dose-response relationship. This blue line is early term, this is full term, and this is preterm. So the same story emerging very, very, very clearly indeed. And here you have risk of heart failure with the less than 28-week gestation babies having this very, very substantial increased incidence rate ratio of heart failure in early adulthood. And then, I think you've got the message now, but again, here, strong risk factors, preterm and early term birth, very strong risk factors for the development of chronic kidney disease. Again, this is data taking us up to 40 years, and you will see this purple line for very or extremely preterm remaining substantially elevated throughout life. Most recently, and again, these are data in press, we have evidence of a molecular corroboration of what we are now calling evidence of a phenotype of accelerated aging in the preterm population. All of the conditions I've described for you typically present in late middle age, and yet we are seeing them present in early adult life. So this suggests, as I say, a phenotype of accelerated aging, and we now have data that shows molecular corroboration in terms of a difference in telomere length and the distribution of long and short telomeres. So here, this is a small study we completed last year. Here you see percentage telomeres of shorter and longer lengths, and the dark bars are men. We have preterm men and term men. The pale bars are women, preterm women and term women, and you will see that the men have a substantially increased preponderance of shorter telomeres compared with women. Preterm men have more short and fewer long telomeres compared with term men. But we're not seeing, at this age, these were individuals who were aged, again, 19 to 25 years. They were young adults. And in this study, we saw no difference in the women. So it may be that the women are protected to a certain extent, but these features will appear, but will appear slightly later. So the emerging picture is this. I've given you a snapshot of data. I could give you data from a whole series of other organ systems. But we have evidence now in the published literature of an increased risk of asthma, allergic rhinitis, so immune-type diseases, cardiovascular diseases, a whole hodgepodge of other sorts of illnesses and complications, epilepsy, retinal detachment, testicular cancer, evidence of transmission into the next generation with a greater risk of preterm offspring in women who were born preterm, and as I've shown you, a reduced lifespan. We also have metabolic diseases, gestational diabetes, type 2 diabetes, the metabolic syndrome, and so on. So evidence of really perturbation in every single organ system. And the question, therefore, has got to be, what is causing this? But I think that, and time doesn't permit me to go into, in detail, the possible causal mechanisms that might underpin this, but this is a very, very rich and ripe area for research. And I do predict that in the next 10 years, we will understand considerably more. I think I'm not running out of time, so I might just mention some of the causal mechanisms that have been put forward that might explain some of these findings. And of course, folk have been addressing issues such as, is it an altered microbiome? Our babies are the heaviest patient group to receive prolonged antibiotic exposure. This may be perturbing their microbiome for a prolonged period, for life, we don't know. And this may, for example, alter energy harvesting. It may therefore alter the tendency to develop abdominal obesity. It may be disruption to, Paul Leeson's group has suggested that it is disruption to angiogenesis and the microvasculature. Others have proposed that it is actually not exposures and aberrant trajectories that are established in utero, but it is more to do with the practices that we provide for very preterm babies in our neonatal intensive care units. So there is an immense series of possible causal mechanisms and biological pathways that remain to be investigated. And at the moment, the summary bullet point I can give you is that we just do not know what underpins these phenotypic characteristics and functional outcomes. But the message for us as neonatologists is that neonatal practices provide opportunity to worsen or improve lifelong health. And were I speaking to a neonatal audience, I would talk about all of the things that we do in neonatal intensive care which might actually add to the problem or hopefully alleviate and attenuate the problem. But I guess the important message for this audience today is that birth gestational age is of great relevance to my adult medicine colleagues. There are some very practical messages to emerge from the data that I've shown you. First of all, if an individual has been born preterm, it is particularly important to, for example, avoid potentially nephrotoxic exposures. For us as neonatologists, as I've said to you, we need to accept that many aspects of neonatal care are very, very poorly evidence-based, and we should consider them experimental. There is a huge debate amongst neonatologists about the right protein intake for preterm babies, about the appropriate growth velocity for preterm babies, about the appropriate ways to manage their patent ductus arteriosus, and so on, and so on, and so forth. And so there is a great danger, which I think does have resonance throughout medicine, that we should really avoid protocolizing non-evidence-based practice, because that really detracts from our ability to subject these medical practice uncertainties to the test of randomized controlled trials. Other practical things we can and should be doing is counseling parents, and later, of course, the children themselves, about safeguarding their health. And I think children should know if they were born preterm. We should tell them they were born preterm as soon as they are able to appreciate and comprehend that information. And as they grow older, we should explain to them that it is particularly important for them. It's important for everyone, but it's particularly important for them to avoid risks for progression of chronic non-communicable diseases. It is absolutely not acceptable for a very preterm baby who's got major risk of chronic respiratory dysfunction to be exposed to smoking or to a polluted, to poor air quality and a polluted atmospheric environment. That is going to make matters worse. And within the neonatal profession, there is now a huge debate about the extent to which we should be screening, actively screening, as opposed to passively and opportunistically monitoring for hypertension, diabetes, dyslipidemia, and so on. So this debate, certainly in my circles, is definitely going to hold sway over the coming years. And I hope, I predict, and I very much hope that, again, adult medicine colleagues are going to be intimately involved in these discussions. But I would also end with saying that, of course, we all need to be supporting research to identify mediators, because at the moment, we haven't got the foggiest. So ask, please, about gestational age when taking a medical history, and I would dearly like to see that advice entered into every adult medicine teaching session, training program, textbook, or online educational asset of any kind whatsoever. So to summarize, the life course of preterm birth is new medicine, because these children did not survive in previous years. But there is growing evidence that preterm birth is a major risk factor for adverse adult outcomes, and I would like to suggest to you presents a phenotype of accelerated aging. There also seems to be strong and growing data to suggest a continuum of effect, a kind of preterm dose-response relationship. The research to understand the biological pathways that have been disrupted, the candidate effector mechanisms, and indeed to identify potential interventions has only just begun. But this is the challenge for neonatal medicine, to identify, to alter and improve these aberrant health trajectories. But I'd like to end on a positive note, because you can imagine that when I speak to pediatricians and neonatologists about this, there's a kind of gloom coming over the audience. But I would like to end on a positive note, because I'd like to suggest to you that this natural experiment of preterm birth and the success of medicine, which was not possible in previous generations, in enabling very preterm individuals to survive, is also a cardinal opportunity to understand the impact of early life exposures and improve health for coming generations. This is a natural experiment that should help us understand the early developmental origins of health and disease. And I believe that by much greater collaborative study across specialties and disciplines, we will actually improve health not only for our preterm babies, but actually for all babies, which means all of us. So I'd like to end by saying thank you very much to my research group, some of whom you see here, and of course to the babies and families who take part in our studies, all of our collaborators and all of our funders. Thank you very much for inviting me.